I'd like to welcome everybody to Lutheran Child and Family Services of Illinois Annual Stakeholders Meeting. My name is Mike Bertrand. I'm the President and CEO here at LCFS. I'm thrilled to have so many stakeholders out with us today on this very important topic. Both some of our private agency partners, our public partners at DCFS, our congregational members, our supporters, my bosses, our board of trustees. It's great to have this room filled, as well as many of our staff here at LCFS. This is a very important topic to us. I'm not going to get too much into as part of the presentation later. She'll be talking about our journey, but we've embraced on a acronym we use as WIDE, which stands for making sure that we are a welcoming, inclusive, diverse, and equitable organization. Through that, we've made a commitment to also be an anti-racism organization and not just be on the sidelines, but to make sure that we are actively out there fighting racism within our society, which led us to look at our own backyard of child welfare, knowing that this has been a national issue, and we are pleased to be partnering with many of the folks in this room, including the state, on how Illinois can take a leadership role on this. So that's our goal today, is to introduce this topic and have everybody become educated and hopefully join us in this effort. If you look at your little packet, you'll see the agenda for the day is on page 1. We will try to stick to that as we're starting on time. So we will start with Dr. Fred Wulczyn from Chapin Hall. As many know in this room, he'll be kind of setting the context for us. And then Beverly Jones, the LCFS Vice President and Chief Operating Officer, will be talking about LCFS's journey and some of what we've been able to do. So I'm going to start out by introducing our keynote and our stage setter, Dr. Fred Wulczyn. His bio is in there, but I'm going to hit some of the highlights. He's a Senior Research Fellow at Chapin Hall at the University of Chicago and the Director of the Center for State Child Welfare Data. The work of the Data Center is organized around the use of research evidence in public and private child welfare agencies. The Data Center provides support to more than 20 states around the U.S. and touches broadly on the problem of increasing research evidence, use, building opportunity. I've got to use my glasses. Creating capacity and increasing motivation. Dr. Wulczyn's work is focused on how states respond to children who are unable to live at home. He brings a multidisciplinary perspective to the work, drawing inspiration from disciplines such as mathematics, population biology, human development, sociology, system dynamics, and social work. When trying to schedule pre-talks for this with Dr. Wulczyn's assistant, we never knew what state and or country he was in. So he's a well-respected individual, and we are very pleased to have him. So please join me in welcoming Dr. Wulczyn.
Thanks, everybody. I can't tell whether I'm making opening arguments or closing arguments. I appreciate the introduction. I generally prefer name, rank, and serial number, so that was very gracious of you to mention some of that. Half of it's true. I want to start out with a few comments in the interest of full disclosure. I come from a long line of Lutheran ministers. I feel it's important to say that whenever I'm in the company of the church in some way or another, because if I transgress in some way, I'm hoping for a little dispensation as a consequence of my acknowledgement of this much. Also, if I lapse into a preachy tone, that's genetic. Not so much a preference of mine, but it is something that I was born with in terms of, and seriously, it's an interesting issue for my family, because it was my great-grandfather and my grandfather who were missionaries, Lutheran missionaries in East Africa. And so the issue of whites and blacks, Africa, the relationship to what happened historically, and whether or not and how our family may have had a role in what has happened is an important discussion that we as a family have on a fairly regular basis, particularly since the time of my mother's death, when certain facts about family history came forward, and we had to address and acknowledge as much. She was born in Africa, lived there for 8 years as a young girl. So the stories and the history and the significance of those experiences and how she brought them to our life is important from my perspective. I would ask you that you do one thing today, and that is please don't walk away from this conversation thinking, I don't believe this is an extremely important issue. I'm going to raise some questions, because I don't think we know as much as we think we know. So I want to raise some questions. That's what we do at the university, what we do at universities. It's an important role in our society. But please don't think that I in any way, shape, or form, do not think that this is an extremely important issue. I am embarrassed by what people say about people who don't look or think or act like them. In terms of our presence internationally, as a representative of the United States, as I said, I'm embarrassed by how we treat our fellow human beings. Oftentimes, I'm also often very proud of how we treat our fellow human beings. But it's the part where we're, in some way, act in a way that could be more humane, more kinder, gentler, more accepting. And it's to that truth, to that world, that I devote my work. And so I'll tell you a little bit about what that looks like. I'm going to talk about supply effects and the black-white differences in the use of congregate care. How is that for a riveting title? But it's an important question. Congregate care, as you may know, has been a target of the Congress in the United States for some time now. They are constantly reviewing the ways in which the federal policy we're going to constrain access to congregate care because we believe it's not optimal for kids for a whole host of reasons. And whether or not there's evidence to back that point of view or not, it nevertheless is a target of federal intervention in relationship to states. And if it turns out that black kids are more likely to use congregate care, and congregate care is this thing that has negative consequences on the whole as opposed to positive consequences, why are more black kids going there? What is it about that system that leads that to happen? And the question I will ask is, first of all, does it happen? And second of all, does it happen in the same way everywhere? This is a large country. What am I not doing? Oh, okay. It's a large country. It's a diverse country. And it may well be the case that how we see or understand the use of any type of care, but in this particular case, congregate care, why do we expect that it's going to be the same? In the South, in the North, in the West, in poor states, rich states. Why do we think it's going to be the same? And so the exploration today is simply to ask the question, well, is it the same everywhere? And then what would we do with the consequences? So that's the goal of the conversation, of work for my sponsors. This is supported by the W.T. Grant Foundation in New York City. Kim DeMont is the program officer. They fund a program of research under inequality, and that's the result of where our resources come from. I think we can safely say that there are significant differences in the type of contact that black children have as compared to white children. The differences with regard to Asian, Native Americans, Hispanic, Latinx kids, also an important subject for conversation, but I've only got a certain amount of time. Historically, our questions about disparities have focused on, are there disparities? So a lot of the research that my colleagues do asks the question, do black kids have different experiences than white kids? I'm going to change the question a little bit and say, where are they the same and where are they different? I already mentioned that, but that's a slightly different question and an important one because we pay much less attention. And when we want to think about institutional racism, bias, whether it's at the worker level, the systemic level, we need to understand variability in disparity, not just simply that it exists. We're going to look at a key decision, whether or not any child goes into congregate care. That's a big issue, as I mentioned. And it's generally omitted in studies of disparity within the research community, in part because there's so much to do in regards to this and other issues that this is one of those issues that we're getting to a little bit later on in the narrative about how child welfare research has sort of addressed this problem. As context, I want to make note of an article in the New York Times circa early 1970s, when the New York Times was reporting on the resolution of a lawsuit in New York City regarding access to congregate care, and a lawsuit brought by the American Civil Liberties Association. At the end of the article, the executive director of the Jewish Child Care Association proudly announced 52% of the kids in our group care are black kids. They were proud of that fact. Why? Because for the history of child welfare services in the United States, or in New York City, black kids were denied access to Jewish and Catholic agencies. Why? Because they were Protestant. And so the lawsuit was brought to bear that these are publicly funded services and black kids can't get in. So they brought a lawsuit, they won the lawsuit, and that opened the door. So the point is, this is a very diverse problem with different nuances depending upon the part of the country where you're talking about. So now, today, the concerns are there are too many black kids in New York City's child welfare system. There are a host of reasons for that concern. It's true, but I just wanted to point out that it's important to have somewhat of a historical perspective on the issue and how did we get to where we are today. So, I've already talked about that a little bit. So, the title said supply effects. What do I mean by that? In the healthcare literature, there's a thing or a saying that goes something like this: a built bed is a filled bed. So that might be a being filled. In order to sustain a congregate care facility, a group home, an institution, a residential treatment facility, if you're getting paid on a daily basis for a bed being filled, there's a tendency to want to fill the bed. It's the system we've designed. I'm not impugning the motives of the folks who operate that system. It's the one we designed. If we want something different, let's design something different. But the idea is that there's going to be a tendency to fill the bed. And our question is, well, if that's true, maybe it's not true in the same way everywhere, so that we might be able to say, well, this is a place where the supply effect is strong, this is a place where the supply effect is weak. And then what are the tendencies of children to go into congregate care settings in places where the supply effect is strong as compared to where it is weak? Am I making at least a little bit of sense? All right, so this notion of a supply effect, I'm going to call it the signal, the supply signal. So when I use that phrase, this is what I'm talking about. The other thing I want to talk about is similar places. It's important to compare what happens to black and white kids, assuming that they're in the same place. There are lots of places in the country where there are no black kids. Lots of counties. It's really kind of surprising. There are no counties in America where there are no white kids. But there are actually quite a few counties in the United States where we actually don't have any black kids living because of a whole host of reasons, not the least of which would be segregation. But the reality is there are places when you look around, there are no black kids there. So it's hard to talk about disparity in the places where there are no black kids because you don't know how they would be treated in those places. So we need to control for the similarity of the context in which kids, this is happening to them. And what we're basically going to say is that supply effect is one attribute of context that we're going to be interested in. We want to look at the risk of going into congregate care for blacks and white kids in places that have the same sort of context as measured by this notion of a supply effect. So we're going to look at 17 states, 1,271 counties, and ask the question, did this child in this state, in this county, ever experience a congregate care placement? There are a lot of ways we could look at that. How long did they stay? Did they step up? Did they step down? We're just asking the simplest of all possible questions. Did they spend at least one day in what's called a congregate care setting? And that includes shelters, institutions, group homes, residential treatment, as the states define it, and it's defined in a variety of ways across the way. Just very quickly, we're going to talk about the signal, no signal. We're also going to look at child-level characteristics, obviously race and ethnicity, gender and age, because there are big differences based on age, gender, and ethnicity in terms of who goes in. And that's a way to simply say, well, we want to look at similar kids in similar places and see what happens. Is that tracking so far? Sensible? So just on the supply effect, how do we know there's a supply effect? It's because admissions and discharges move together.
If you have a bed constraint operating in the system, and there are kids leaving the system, there will be kids coming into the system. If there are kids leaving the system, there will be kids coming into the system. And we just look over a long period of time to see whether or not admissions and discharges tend to move together. Ups and downs. Is there, in a sense, a discharge echo for admissions and an admission echo for discharges? And we listen for the echo, and if we find it, we make note of it, and we describe the county as a consequence. And we do that over 520 weeks. We're doing that every week. Kids come and go. For each one of those 520 weeks, we're asking, is there an echo that I can hear that kids left? And then I look to see whether or not there's a bunch of kids that come in on the heels of a bunch of kids leaving, right? And if there's a strong signal, they move very closely together. If there's no signal, you can't see the pattern in the data. So, on to the meat of the potatoes. So, in this collection of states, I forget, 138,000 kids, 44% of them will have one day. These tend to, let me back up just so 10 to 17-year-olds, 138,000. 44% of them will spend at least one day in congregate care. That's a lot. The next panel down is race. You can see that half the black kids will spend time in congregate care. Only 39, almost 37, or almost 40% of the Hispanic kids and 44.5% of the white kids will spend time in congregate care. That's the disparity. The 50% compared to the 44%. Now that might not strike you as very large. Why are we concerned about? Maybe that's just the way things go. But I would say that this is 138 kids without regard to the state or the county where they live. So we don't know that this is how I would describe Illinois and California and Vermont. It would be nice to know whether or not it's 44% across all, or 50% and 44% across all of the states and counties, or is it some places is it bigger and in other places is it smaller? So we can't sort of walk away from this saying, oh, well, that's not that big an issue. Males, 48% are going to experience placement into congregate care. Only 41% of the girls. You can see the strong relationship between age. 23% of the 10-year-olds will go into congregate care. 56% of the 16 to 17-year-olds. That's sort of known already. But if a state happens to have a lot of 16-year-olds in its system, it's going to use more congregate care than a state that has more 10-year-olds. So we want to iron out these differences before we make judgments about the magnitude of the issue and before we try to explain it in terms of the underlying mechanisms or the way the systems operate and the possibility that we're talking about some kind of institutional structure that is biased against blacks or in favor of whites, and we'll get into that as we go. Urbanicity, interestingly enough, the medium metro areas is where congregate care is most likely. Now, if you think about New York City, that's where all the congregate care agencies are. They're all in the suburban area around the urban core. So this might be a legacy of where residential centers were built 100 years ago, or not, as the case may be. It's lowest in the non-core counties. These are the rural counties. We could talk about why that makes sense. In urban areas, it's sort of at the midpoint, right around 43%. So there is a geographic component. And then you'll notice this no signal. If you live in a county where there's a strong signal, that is a strong supply effect, 46% of the kids in those counties will experience a congregate care placement, as compared to only 38% of the kids in places where we can't detect such a signal. So that's an interesting finding. So you're more likely to go into congregate care if there's a supply influence on demand. So we want to track that closely, because we'd be interested in knowing whether or not that effect has a differential impact on blacks as opposed to whites. That's where we have some interesting possibilities, that if for some reason the supply effect works differently for black kids than it does for white kids. Because now we're starting to explain the variability. So, state variation in the likelihood that a child will go into congregate care. This is enormous variability. whether you go into congregate care or not, holding constant your clinical profile depends on what state you're in. It's an accident of geography as much as anything else. All right, now pay attention to state number 7. These are not in any kind of alphabetical order, so no risk of deductive disclosure. Look at state number 7. That's the state where the kids are the least likely to go into congregate care. And then look at state 13 or 12. Those are the places where you're most likely to go into congregate care, because now we want to look inside the state, right? That's the state with the highest rate. Not only does it matter what state you're in, it matters what part of the state you're in. These are the use of congregate care by kids by county. There is not one narrative. There are many narratives, and we have to relate our understanding of disparity to the variety of narratives and see if we can't organize the narratives not into, there are, I think, 49 counties in this state, not into 49 narratives. We want to try and organize the narrative into a smaller number. But this is the variety of experience that kids are exposed to because of the systems we're building. This is the state with the lowest rate of entry into congregate care. Again, there are 90 counties in the state, 90 plus counties. There is a variety of narratives that are operating here. And we want one explanation. The political will to sort of dip into and understand the diverse narratives that are taking place, we want one answer. We want one explanation. There is not one explanation, because these are all uniquely different ecological contexts, and until we understand the influence of place on the chances that something will happen and then integrate that into our narrative, we are going to be, we put ourselves at risk of trying things that not only are they not going to work, they could actually make things worse. So this is the disparity in the use of congregate care. So all I've done here is I've divided the 50% by the 44%, and the ratio of those two percentages is about 1.22. So that's the basic measure of disparity. When I take into account the age, race, and gender of the kids, the black-white difference is basically the same. When I take context into account, the strength of the signal, the level of social disadvantage, and urbanicity goes away. That line across, the red line, the red horizontal line says there's no differences in the blacks and whites. It disappeared. So that's interesting, but I'm not prepared to accept that as an explanation or the final word, because there's still lots of things going on here, not the least of which is, well, we saw that there's a lot of variability in the county and a lot of variability in the states, and so California contributes more information to this analysis than Vermont. More kids in Vermont, in California. So so is this the state of affairs for the nation as a whole, or is this the state of affairs in California? We're just sort of overgeneralizing from that this little bit of data. So we have to take size into account. And we also have to take place into account. So now, who uses congregate care? So I'm looking at 3 variables here. Is it an urban county? Is it a place where there's no strong signal, the supply signal? Is it it's a 10-year-old female who's black? That's on the left side of your screen. And so if you live in an urban area where there's no strong signal, you're 10 years old, and you happen to be a female who's black, you have about a 14% chance of going into congregate care. If you're a white girl in the same situation, then you have a slightly larger chance of going into congregate care, but not very much larger. And if you go all the way out, if you're in a non-urban area, in a place where there is a supply signal, you're 10 years old, you're female, and you're black, you have a 30% chance of going into congregate care. So for this population of black females who are 10 years of age, The risk of going into congregate care ranges from 14% to 30%, depending upon where you live. That's got to be part of the narrative. If you're white, you see the same general pattern, but the change over location is not as great. But the least likely are the white girls who are living in urban places where there's no supply effect helping to determine demand. That's the bar on the right. That's at about 15%. And then it rises a little bit if you're in a suburban area, about the same if you're in a non-urban area. And then if you're in a place where there is a signal, that's one of the things to note, that if you live in a place where there is a supply effect on demand, in each of those places, regardless of age and gender and race, elevated rates of entry into congregate care because the supply is influencing what happens to kids. This is a system effect. This is something we designed. If we want to change that, we got to design something else. It's not like this came down from the mountaintop and said, thou shalt design congregate care systems that look like this. You have options. We have options, right? We might want to measure the disparity. So now all I'm doing is comparing those two charts side by side and computing the ratio of the percentages. For urban girls that live in urban areas who are 10 years old, where there is no supply signal, there is no difference between the risk of a white girl going into congregate care and a black girl going into congregate care. Where does it matter? If you're in a non-urban area where there is no supply effect, that's where the disparity is greatest. Now, there's just one little problem with this chart that we're correcting in the next chart, is we still haven't accounted for size. Again, large counties could be contributing more information to this than others, so the last panel on the right takes care of that last bit of the narrative. And what you can see is it sort of compresses things a little bit, but the narrative largely stays the same. Girls who live in urban areas, 10 years of age, where there is a supply effect on demand, there's very little disparity between whites and blacks. Now, this is a geographic matter. Where do black kids live? They're concentrated in urban areas. Not exclusively, but their exposure to urban systems is different than the exposure of whites to urban systems. And when we look inside an urban system, we don't see unequal probabilities of going into congregate care. We see approximately equal. If we want to find the disparity, we have to go to non-urban areas. We have to go to suburban areas. Now, what we know, for example, about the migration of poverty out of urban centers into suburban and medium suburban areas, that may be part of the narrative that's here. This isn't the end of the line of the story, but I wanted you to see that there isn't one narrative. It depends on who you're talking about and where they come from before we can begin to sort of see the variety of stories that go into what happens to kids and what is the role of institutional structures, bias, all of the things that bring us here today to try and understand, about which we don't really have a full narrative. So, as I mentioned, the Congress is trying to regulate. So don't worry about the numbers at the bottom. That is to remind me of what's going on here. But there are some states that regulate the use of assessment as a step for getting into congregate care. To get into congregate care, somebody needs to assess you and demonstrate the fact that that would be good for you clinically. The federal government just passed a law that said states shall use an assessment. So that ought to have a positive impact. The problem is it's a little mixed. So use of an assessment increases the use of congregate care, but reduces disparity. So it increases it, makes it more likely. Assessments reduce the supply effect. So I do an assessment and it mitigates the influence that supply has on utilization, but more so for whites than for blacks. So now we're looking at differential effects of policy. Assessment increases the use of congregate care, but reduces disparity because the effect of using assessments is greater it has a bigger effect on the likelihood that a white child will go into congregate care than for a black child going into congregate care. So I do an assessment, and I'm a white kid, I'm more likely to go into congregate care. That's a good thing because it reduces disparity. Or is it? If it's intended to regulate access to group care, why is it having a bigger effect on whites than blacks? And what is the narrative that lies behind that? Because that's how kids get into congregate care in some states. The state requires people to assess the need. So we might say, well, we should do more assessments. As I said, the federal government just said that. Well, what's the impact of that going to be? The common sense interpretation of that law is that, well, if it's not good for you, or its use as an intervention is limited to certain kids, then let's assess for those kids and then find alternatives for the kids who don't assess in that way and use congregate care in some limited way for the kids that do, but the assessment will have a positive impact. Only if it creates greater equity. And it's not automatic. Depends on the baseline circumstances of the system where you're already working. What are the chances? How does it impact? These are questions that we're not paying great attention to. So, it matters where we find disparity. It is not the same for all places and all populations of kids. Induced demand, supply-induced demand affects the likelihood of placement into congregate care. There is no state that I'm aware of that relies on a robust model for bed planning. If supply affects demand, and we don't have a planning process that says, you know, for this county, this region, this state, we're going to need about this many beds. And communicating that to the provider community that says, this is the market for beds. We're going to have this many beds. And you can grow or shrink or merge or go out of business, but this is how much we're buying. There are very few states, if any, that I'm aware of that actually engage in rigorous bed supply planning. I bet they do at Northwestern Medical Center. I bet the Department of Health does, figures out how many times we're going to need space for coronary bypass surgery in geographic area X. Because when you show up at the door needing a quadruple coronary bypass, you want there to be a bed. You don't want them to say, well, come back next year. So this kind of rigorous planning, why are we not doing this for poor kids? White, black, Hispanic, Asian, American Indians, why do we not take the time to figure out how many beds if supply induces demand? Reliance on screening methods would appear to be a weaker strategy in the face of supply pressures. Supply-induced demand trumps, pardon the expression, assessment. It's the more powerful force. I can strengthen my legs so that I can jump higher, but I'm limited by gravity. We can assess all we want, but the tendency to fill beds, the need to fill beds, because of economic reasons we've built into the system, will overcome that. The role of relative judgment in the face of supply pressures is poorly understood in virtually all child welfare contexts. We're all willing to talk about how many people here think that the child welfare system has enough money? That's a supply constraint. We can't buy enough of the stuff we think we need to run the system. There's almost no productive literature on the role. What is a supply? What is a a resource constraint. We can say money, workers' time, go through that list. But in terms of empirically establishing, well, what is the effect of these constraints? We assume that the constraint reduces our options, but some constraints create options. They operate on both sides of the constraint, make some things more possible, some things less possible. We just, as social workers and advocates, what have you, we're always worried about the negative consequences of constraints. But it's always a two-sided coin. We know nothing about the other side of the coin. How is it that we've adapted to the constraints we live in, and then how do those adaptations influence our ability to solve these seemingly intractable problems like institutional racism and bias and those things so that we can have a more equitable system? Right now, we can't say whether or not the white people are getting an equitable, fair shake in the system, let alone the black people or the Hispanics or anybody. These are just questions we want desperately to understand. But in a sense, research is action. We need to spend time understanding this very complicated system. I'm not making it complicated. If I had my druthers, I'd have designed a system less complicated than the one we have. But this is a complicated system. It's difficult to follow the threads of causality that create the narratives that we're trying to change. But if we're serious about this effort, the thing that brings us here today, then we have to dedicate ourselves to a deeper understanding of those narratives. Otherwise, good luck to all of us coming up with a reasonable solution. Thanks for your time.
Thank you, Dr. Wulczyn. We have left an ample amount of time for questions and discussion of both of our presenters, but also, as I'll say, the time to as a group, discuss this important topic. So our next presenter is Beverly Jones. She is the Vice President and Chief Operating Officer here at Lutheran Child and Family Services. You will see her bio in your packet. Beverly has led child welfare systems and efforts around the country. She joined us here at LCFS in 2009, and I've had the pleasure of working with Beverly that entire time. And my earliest sort of remembrance of Beverly as it relates to families and children and the families that we serve started with, well, there's fathers too. Why aren't we trying to engage the fathers in their family, and won't that produce greater quality for children? And from there was, what are we doing around children of color? Are they being treated fairly and the same within the state of Illinois and within Lutheran Child and Family Services? And she's going to now talk about kind of our journey and how that's led us all here today. So, Beverly Jones.
It's good to see everybody, and I'm glad all of you came today. I want to thank Fred for his presentation. I am not a researcher, don't pretend to be, but I am curious and inquisitive. I love data, so those of you who are not on the program side, you need to stop saying program people don't care about data. Yes, we do. It is about asking the right questions and figuring out how we might get the answers to them. So I'm presenting on what I call our journey to address the issue of systemic racism. And I'm just the presenter. I want to acknowledge many, many people who have helped around this effort. And I want to thank our former CEO, because this all started under Gene Swaybaken's leadership. So thank you, Gene. To all of our board members who have embraced, participated in this effort, I want to say thank you to all of you. And then we have what we call at LCFS an Inclusion Council. And our two co-chairs are here, Brent Deers, stand up, and Latasha Robertson. So at the end of the as well as there are several members of the Inclusion Council present, so stand up and you can feel free to talk to them about this work and our conversations we're having around this. So thank you, guys. And then I need to do two special thank yous. One is to my dear friend from the department, Bob Blackwell, who is not only a colleague, but a mentor and someone who I can call and vent with safely and privately, but also always leaving me encouraged. So thank you, Bob. And then to our person who has worked closely around data and answering my questions, my dear colleague, Douglas Cabell. So thank you, Douglas. So I want you to, if you don't remember anything, I want you to think about our work beyond are we meeting our contractual obligations? What is the impact we hope to have on children and families? So before you is LCFS population results children, that we want all almost 3 million children in Illinois to have loving forever families. That is our contribution and that is our goal. It is not okay that we have one child without a loving forever family. So remember that and ask yourselves, what is our population result that we hope to contribute to? So I had mentioned the Inclusion Council. I'm going to spend time. Let me just say this. This has been a journey over a number of years. Started out with lots of conversation in the Inclusion Council that has been in existence for over 30 years within LCFS. We have all our offices and programs are represented on the Inclusion Council, all levels of staff, and I'm a member, but I am their colleague at the moment. I am not the corporate office, so every voice, every opinion matters and counts. So our mission, and Mike had mentioned this earlier, is to support our agency in becoming a wide organization. You'll hear wide a lot in our agency. Wide representing welcoming, inclusive, diverse, and equitable. And one would say, well, aren't you that already? And I would say, no, and I guess, and I would put before you that I think all of us, regardless of our agency organization, could work on this. So we began with lots of conversation about what this means and what it would look like. And I'm going to talk about Crossroads training in a bit, but we really wanted to promote equity in our work and that the members of the Inclusion Council really provided leadership and advocacy around this issue, not only within our agency, but with any of our partners, including families. So the last 2 or 3 years, our focus has been around the impact of race and sexual orientation, gender identity expression on outcomes for children and families. How did it matter at all around us being able to achieve our population result for children of color? So we went on a journey, and I call it a journey because you never really reach the destination. You keep trying. That the Inclusion Council really identified these 4 areas in which we wanted to concentrate. How the importance of a safe environment for our staff, where all staff felt welcome included in our organization. What were the barriers to that? recognizing that events and conversations have occurred in our agency that were the opposite of welcoming and inclusive and equitable, and that silence only contributes to the issue. It does not address it. So, as we had many conversations, and I have no financial gain in this book. I have given out copies to people to read, and I said I really should write the authors and say, I think you, I should have some financial benefit. And I even forget how I came across this book. I think I just got an advertisement suggesting the book. And I read it and said, this is a great way to move the conversation away from, you're calling me racist, I'm not a racist, yes you are, no I'm not, and nothing changes. The book really helped provide a framework from which we decided action could be taken. And there are 2 female professors who got permission from a CEO of a child welfare agency to visit any and all of his offices, and they expected that going into an agency full of social workers, that the issue of race, culture, and gender identity would be talked about all the time. And what they discovered was absolute silence around that issue, those issues. And they were taken back by that. They were surprised by that. And it talks about what it means to be colorblind versus color cognizant. So, you should read the book. As a result of that, the corporate officers read the book, some of the Board of Trustees read the book. I gave it out freely to directors and supervisors to read the book so that we all would come together and have a conversation that moved it from the personal level about who's racist and who's not. Because the fact of the matter is, the messages around race impact all of us. And in very different ways sometimes, but sometimes similarly. So let's move away from about who's the most racist person in the room to what do we do around recognizing the impact of race. And as a result, and in your packet, you will see that we developed an organizational commitment around systemic racism. The Inclusion Council worked on this. Corporate officers reviewed it and signed off on it, and the Board of Trustees adopted it. So if you go to any of our offices, I would hope that from a few years ago, you would see our offices very differently. This statement is posted in all of our waiting rooms, as well as the pictures of who we have hanging on the wall represents the people we serve. So that if I walked in one of the offices and I just wanted to do a visual check-in, I would see me in a positive way. So we began to do some other small steps. One is that talking about why it is an issue and a topic around our new employee orientation. We have language, and I think all of this is part of your resource guide. In every employee's evaluation, there is a commitment around, and they have to set a goal. What are they committing to around race equity? And it could be, I'm going to attend in March the 2.5-day Crossroads training. You would, in our 5-year strategic plan, there are action steps around why. As well as we interview and hire new people, we talk about the importance of this work and what we are doing around this issue, and so that people are prepared to know what kind of agency they're coming to work for. I'm not going to go through all of these. These are things that we have done as we move forward around addressing this issue. I do want to highlight the quality review process that we joined the department in doing. There were a number of birth parents who were expressing concern about how they were being viewed, treated, in terms of getting their children back. And Mr. Blackwell invited all the agencies who served that geographical area to come to one of the birth parent cafes and hear and sit and listen to these parents talk. And it was very, very powerful. It was also embarrassing. And it became real clear that fathers were dismissed. And I remember people talking about why is it people are concerned, particularly fathers who had daughters. Like, why was the question is who's going to do their hair? I have a daughter, and I'm not good at hair. And I feel badly about hers. I mean, I could do the basics, but anything fancy, not going to happen with me. How many mothers do we ask, how are you going to do your daughter's hair? And then we have mandated that supervisors and above attend a 2.5-day dismantling institutional racism training that is done by an organization called Crossroads. Other staff are encouraged and are allowed to go. The mandate is on the leadership, starting with supervisors and above. And let me tell you, that has not been without controversy. So, having done all of those things, we said, well, now what? How do we move this forward? And Lutheran Services in America, and you can read, have a population result. And we joined a cohort of agencies, and around our population result we wanted to impact. And ours was around race equity as it pertains to achievement of permanency and the length of time children are in care. So the question is, what does our data tell us regarding disparate outcomes in racial equity practice? And if disparity exists, what are we going to do? And we are a statewide agency. So we did a first cut of looking at statewide. And then I think one morning or one evening, I walked into Douglas' office and said, I think we need to do this by site and not just the state data. And he did. And disparities existed in all of our sites, some more acute than others. But we had an issue. The length of time to achieve permanency. Varied from site to site. And we did it by African American children as well as Hispanic children. We first did everybody together, but we separated them out. So, Mike and I said, now we don't want to get carried away with setting a target. We're going to be really conservative and hope we are able to do this. So September 2018, we committed that we would increase the number of children of color to achieve permanency by 5%, and we would decrease their length of stay by 5%. And you can see we easily surpass that. Much to my surprise, because I was nervous about whether we were really going to be able to do this. But we did. I will also say that, and I don't know that, in fact, I know I didn't do this slide. And then you can see days to permanency and in the year, the decrease we had for African American youth, 14% decrease. So I was convinced, as well as Mike, that the permanency outcome was going to be predominantly adoption. And this is statewide. So we have sites who did far better. I mean, really knocked it out of the ballpark on both of these measures. But everybody surpassed the 5% target. And this will show you for Latinx children, the same result. And they had a 40% decrease in the length of time in care. Now, to be transparent, most of this population is served in 2 offices, our Cook County and then what we call Northern Region, our Joliet, Kankakee, Oak Brook offices. But much to my surprise, we had quite a few in Belleville, which is southern Illinois. But so this data is shared with the directors. I try to do every 2 weeks, at least once a month, we do a check-in. We get data up, they get current data about how well they're doing and where we are, and we have a conversation about, well, what does it mean? And what are we doing differently? We have lots of hypotheses, no research, Fred, but the work continues. So I just knew it was going to be adoption. Well, much to my surprise, 58% of the children who achieved permanency were reunified. And I periodically ask people to send me a summary of children who've been reunified. And I must say, I get upset as to why the children came into care. But more importantly, given why they came to care, I don't know why in the heck we kept them as long as we did. In fact, I just recently saw a little summary of a reunification. And I love, and Mike and I debate this, language matters. And this mom was labeled as having an attitude. Well, what in the world does that mean? And what does that have to do with her ability to parent? Hostile, uncooperative, inarticulate. Those things matter. So, we have no idea what I call the difference makers. I look at the directors, Shelley and Arlene are here, and they know, like, well, what are we doing differently? What are your hypotheses? And so this is our best thoughts. First of all, having data that's easy to understand and read, it's colorful, and it's timely. matters. It's not a page full of charts and lines and you don't quite know what it is. It is, this is what it looks like today. The meetings that I have with staff. We have done what we call practice forums, really looking at the issue of engagement of parents and both parents. And we have a number of staff, supervisors, and workers who are strong advocates about fathers and not forgetting them. So a number of our reunifications have been with birth fathers. Child and family team meetings matters. Where we have them, we don't tell people who they can have. It's supposed to be their meeting. So if they don't want somebody there, that is their prerogative. We don't say, oh no, they have to be here. Is it always during the day? So for people who work, who if they don't go to work, they don't get paid, have to make that choice. Where it is, it should not be in our office. It should be where the family wants the meeting, and they should lead it. I've asked supervisors in particular, what do they think are the difference makers? And I think they feel, in fact, I know, they feel supported in being strong advocates for parents. In a system, and by a system, I mean all of us, who are not necessarily that empathetic to with parents. They feel very comfortable in pushing back. Language, documents, how we write them, what we put in service plans. And I can tell you, I've seen some where we put in one where for a dad that he should live a criminally free life. The man had never had any criminal convictions. All of that matters. And then we try to celebrate not only our big progress at the end of the full year, but on the way. Encouraging people, celebrating them. I'm a note writer to people, so I try to personalize handwritten notes to people, thanking them as I hear about the work they have done. And you have to persevere, because there is nothing easy about this. And you will get frustrated, you'll get angry. It's like, oh, what the crap. So where do we go from here? And we continue to do this. But we need to look at the stability of those families where reunification took place. Do the children who go home stay home, and stay home safely? And being able to track that. Because the issue is good decision-making, but also contributing to that population result. Loving forever families. Now I'm going to go on a rant, and staff will tell you this is a pet peeve of mine. I don't know how and why we have independent living as a permanency goal. My daughter, who's married and has children, and I said to her most recently when I was back east, when are you going to be independent? And that we just take that for granted when a young person reaches a certain age, oh, we'll make it independent living. And people will say, well, they'll get additional services because of that. Well, how backwards is that? Because I would argue most teenagers could use the additional support and services. So if you look at our data, because and I'm willing to share anything anybody wants, there are no secrets here. We do it by age, like who's achieved permanency. Most of our success is mainly 13 and under, with some older youth also. But for the most part, it's the non-adolescent population. And I worry about those adolescents. And then we do need research. But I would also say to people who do that, you need to examine your own implicit biases as you go to help us figure out what the questions are. And what do we do in the meantime? Because we're talking about children in care. So we need to do something. And you need a whole group around you who are committed to this. So as you get tired and are ready to throw in the towel, there are other people who say, oh, no, 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 no. We don't do that. So the critical question I ask, are we comfortable with disparate outcomes? For LCFS, the answer is a resounding no. So I'm going to share, before I say what's up here, I'm going to do a very personal ending. My career, I'm on the end of my career, not the beginning. And as I think about my professional journey, I'm sometimes taken back about all the opportunities that I've had in this field of child welfare. And through that journey, I had incredible teachers, mentors, and colleagues. But what really is the difference maker is that I had a family, and let me describe my family, where my grandparents, my mom, my dad, aunts, uncles, cousins galore. But it was the neighborhood in which I grew, where every child was cherished, encouraged, told they could shoot for the stars and be whatever they wanted to be. So, whenever I was insulted or was offended, discouraged, questioning myself, it was those people who always were there to lift me back up and say, go at it. And as an African American child or adult now, that was important. And in our language in child welfare, we call that a protective factor. Because there were a lot of messages outside of that wonderful community that were not that positive. So that alone drives me to say, what are you going to do as an agency, as an individual, to change the trajectory for children of color? And it takes all of us to do that. Thank you.
Thank you, Beverly. And thank you, Fred, if you would. So our goal today was to challenge us and bring this topic to the forefront. When we engaged with Fred, he said, I'm probably not going to say exactly what you want, but that's okay. In terms of the topic, we was great, stimulate thought, call the researchers to action. Beverly was kind enough to share our journey and share a little bit of her personal journey. But this is the beginning. So we put this again out here to our stakeholders who come from many realms, and now open it up to questions, comments, dialogue, thoughts. If you would please raise your hand if you have a question or you'd like to say something, and our microphone attendants will dash on over to you.
Hi, I just first want to thank both of you for very thought-provoking presentations, and I have actual questions for each of you. Beverly, I'm so impressed by the data, the results that you got from your strategies, and I was wondering if there was specific strategies that you guys used to reduce the disparities, things that worked or things that you thought would work that didn't work, so that the rest of the field could learn from that approach. And then I'll do a separate question for Dr. Wulczyn.
I think we're still trying to figure that out. I think the fact that we acknowledged there was an issue and that it was okay to talk about it and figure out together how we address it was a really big step. I do think, you know, child welfare is never easy, and I've done this for a long time, and I don't think my family really still understands what the work is and how you do it. But I think in these times, and we were just talking about this earlier, if I was coming out of school now, would I go into child welfare? I think the expectations, the demands, the expectation that you're always right on your decision making has to be frightening and scary. And not here, but in one of my previous lives, I had staff say, you know, Miss Jones, you never get in trouble for removing children. You only get in trouble if you leave them at home or you reunify. And in trouble means my name is and my reputation is. And that was so sobering. So I think as an agency, we have tried to create that that it's okay to do reunification, and our decision-making has to be sound. We share it. So it's shared decision-making, and it's not on one person. And that we look at those successes and say, what is the difference here? But it's okay for children to go back home. What's not okay is for them to grow up in foster care. And I think that is our culture now.
Dr. Wulczyn, if I was understanding your presentation correct around the signal and supply conversation, I'm wondering, does it apply when the supply is less than demand? Like when there's, and I don't want to be cagey about it. I mean, here in Illinois, we dramatically reduced the amount of congregate care that was available. And so we've seen this backup of kids in psychiatric hospitals and detention centers being sent out of state. Are there disparities in the way kids are being treated in that pipeline as well, when you have less supply and more demand?
So that's a great question, and so you did understand what I was saying. So I appreciate that. I think the issue is it's a case in which it will work very well, because there's always a steady supply of kids waiting to get in. You're undersupplied, demand exceeds supply, if I understand your point, and I think that's the sort of the narrative here in Illinois, that the reductions led to an undersupply of beds, and as a consequence, what's needed to get a young person into congregate care when it is appropriate is people often talk about failing up, if you will. And so that situation is a unique one in the sense of that how the supply affects demand manifests itself, but it's a particular version of that story. It doesn't say that the story, it doesn't falsify the story. It's just, it's easier to manage by letting kids in. If you have an undersupply, the way you would see the relationship is that kids would stay longer. So each bed is occupied for a longer period of time. Give you an example in healthcare. They look at certain types of illnesses. They look at the supply of doctors and how many doctor visits there are based on whether or not there's an over or undersupply of doctors. So if there's an oversupply of doctors relative to demand, each patient gets more visits because that's how you keep up the work. Each patient gets more visits because there's fewer walking in the door, so each one that does walk in the door gets more visits. In the places where there's an undersupply, where there are an oversupply, where there are more people walking in than the supply, then they don't get as many visits because they meet the demand in another way. The need for visits, not the need for the care, but the need for the visits. And then they compare the outcomes. And there are no differences in outcomes, but they're getting different numbers of visits per physician on average for the same health condition, depending upon whether there's an oversupply or an undersupply of doctors relative to the demand in the population. So these are phenomena that are present in a variety of forms in all of our human services. It's not just the child welfare system, but in the healthcare there are huge disparities in utilization of healthcare based on the type of care available in the region where you are. It stands to reason. We just don't know as much about how that affects what we do as we ought to.
My question is a bit of an expansion on that. I'm over here. And it's related to those outcomes. So it's an interesting question that Andy was asking and an interesting point that you just made. So as you were talking about the disparities with congregate care, you define congregate care as shelters, residential treatment, and all different types of centers. I operate a residential treatment center. And I was trying to think, are you making a case that it's good for people to go into congregate care or bad for people to go into congregate care? And you may not have been making either one, just presenting the data as far as it is what it is. But I was looking at it from the perspective of, is it disparaging that more people of a certain color enter into congregate care versus another person of color? Because I look at it as, for my center, it's access to treatment. So children should have equal access to the treatment that they need. It's not a warehouse, it's not putting a kid in a congregate care setting just for the purpose of putting them in a congregate care setting versus them being in a natural family environment. They come to us for a very specific reason. So if we see disparity between color, there's a group that isn't getting the treatment that they need versus being held from being in a natural family setting or in a home setting. So there's always has to be that deeper dive into the data and looking at, well, what does this mean? What does it mean for outcome? The doctor scenario you just described, regardless of the number of visits a person received, the outcome in their health was no different. So where is the outcome for people who are entering into congregate care? How do those groups look 5 years down the road, 10 years down the road in terms of the outcomes of their life, and how does that look by color?
Right.
To me is a more interesting question than whether they're in or not in congregate care, but it's a very interesting question. Are they in or not in the treatment that they need, and what their outcomes look like down the road?
So I make no judgments about the value, the virtues of congregate care or not. I think what we can say as a field that the true demand for residential care or group care or whatever family care, the true demand is not zero. But it's probably less than what we observe, certainly in some places, the true demand, where the truth of the demand, how it's manifest, is that kids get as much as they need when they need it for as long as they need it, right? That's, if we had an efficient system running that way, that's what it would look like. And so I don't think we know what that optimal amount is. It would help to know that if we were going to be serious about bed planning, so that we could, adjust the supply so that it's less of an influence on what's going on. And then you ask absolutely the right question. So the first place to start, well, how long do kids stay? If they go into congregate care for reasons that are unrelated to their true needs, do they tend to stay longer? Do they tend to stay shorter? And then on and on the outcomes go, the life course outcomes being the ultimate ones. These are all questions that we don't have answers to. In all reality, I mean, we have snippets of answers, but they're pieces of cloth that have yet to be sort of fashioned into a whole cloth that we can use to describe an optimal child welfare system. I think the challenge is, and people do, complain that, well, research, it takes time. We know what we need to do. I'm not sure that we do. And I think the idea that we're going to solve a problem we're unwilling to define thoroughly is not something we would recommend to a family. Let's not take the time to figure out what's wrong. Let's just thrash about trying to solve the problems we haven't defined. Well, we have to ask ourselves whether that's the situation we're currently engaged in with this system. Yeah. Exactly. And what we, with all due respect to the Congress and the fine work of congressional aides and what have you, the reality is when we pass a federal law that addresses whether or not we're going to be allowed to use congregate care in the way we have historically, we don't know whether that law is going to have a differential impact. Is the use of congregate care going to go up in the places where it's low? Is it going to go down? How low can it go? And yet we're passing laws that assume that everywhere that law will apply, it will have a positive effect for the kids that are there, whether the issue is disparity or life course outcomes or what have you. And the reality, from my perspective, is that we have legislative policy making that has, by and large, grown up over a century, where for most of that century, there was very little information available about how the darn system works. And so they've sort of become habituated to sort of making things up and relying on ideology and values, which of course has to be part of the puzzle. You have to do things because you're motivated by values and what have you. But to the extent that there's good empirical evidence about how these things work and how a set of proposed policies will work in the system we have, that's work that has to be done. Otherwise, we find ourselves sort of piling one policy on top of another without knowing whether the effects cancel each other out, are additive. How many people can remember the last time we decommissioned a policy or regulation in the child welfare system?
Can we get to the question over here?
Huh?
Yeah, similar kind of our follow-up. I don't think we can look at residential separately in a sense, because especially looking at length of stay, just like we have children in hospitals waiting for residential, the same is happening in residential. We have children that treatment-wise are ready to leave, but we have nothing to come after treatment. So then that backup gets created. And again, with urban versus non-urban, resources, for example, Southern Illinois, more rural, there aren't any resources. So the only thing you can do to get any kind of treatment sometimes is you go to a different higher level because there is nothing in the community. And the same on then exiting back into the setting where there aren't any resources. How do you facilitate, especially with Family First, on that whole effort of families in the community and being served within a community where there isn't anything? And I think that influences probably the statistics and numbers greatly, then also connected to race.
Absolutely. No, that's exactly the point. That these resources matter.
Hi, I have a question related to, we talk about systemic racism in the child welfare system, but my question is in terms of just the larger society. We're specifically talking about it existing in this system, but how do we work with even bring ourselves with strategies to not necessarily separate the child welfare system, because what I actually see is a parallel process of what's happening in the larger society. It's not that it's just happening in the child welfare system. My question, though, is in terms of educational institutions, what recommendations do you all have for people that are being trained in terms of how they work with, from a culturally sensitive perspective, young people who are in the child welfare system, knowing that the racism exists, or there are race-related factors that are impacting and impinging upon the children? What do you recommend? What do you suggest in terms of different strategies that we might employ?
That's a hard question. I mean, I think from my perspective, and I have a wide variety of weaknesses and a limited set of strengths. And, you know, the thing that I want to know is I want to know what the problem is. And I want to be open, I don't want to become so locked into a solution that I cease to see that it isn't really responsive to the problem. I want to know about how things are getting better, and if I'm doing something and it's not contributing to getting it better, I want to have the strength of admitting that to myself and trying something else that somebody else, a better idea that somebody might have. And that's not a strategy as much as it is a state of mind. I want to solve the problem. And so how you communicate that sort of state of mind, the mindfulness is what some people talk about now, in terms of your willingness. I talk about it as you get into trouble when you own the solution as opposed to the outcome. Figure out what the outcome is that you're working towards and get there. And if something doesn't work, be prepared to abandon it. You know, we're not going to bat 1,000%. You know, we're lucky if you know the reference to the Mendoza line. We're lucky if we're up, you know, if 10% of the time something we do actually works the way we intended it. I would settle for that right now. So getting people comfortable with the possibility that you'll be wrong more often than you're right, but it's through the process of being wrong that you learn how to be right, is helping people with the fortitude to solve problems in that way.
And to quickly clarify on your comment, and at least on the LCFS journey, is a recognition that there's systemic racism in our society, in our country. And if, via that, recognizing that exists within the child welfare world. Via that, realizing that exists within how LCFS does business. And that's where we began our journey and continue along that journey.
Hi, I wanted to say first, I'm just really impressed to see the transparency of sharing the data that you did in terms of LCFS's data from, you know, one year to the next, especially in a setting like this, your annual meeting. I think, when do you ever see organizations do that? So I want to say thank you for being so transparent. So first I wanted to say that, and then I was curious, Beverly, to hear a little more from you about, it sounds like you're pretty passionate about youth not just going to independent living, and since I don't know as much about what the current policies or practices are around that, I was wondering if you could share, are there certain like ages where you all kind of assume they're going to go into independent living, and is there evolving thinking around that?
I think there's evolving thinking around that. And I think the utilization of independent living is influenced not only internally, but by outside people as well, including sometimes the young person's attorney, as well as the court. I think, last year we talked about our regenerations program, which serves dually involved youth who are involved both in the criminal justice and the child welfare system. In that work, they really have been pioneers that there's always family. You just got to keep asking and looking, and you have to check your own standards about who's appropriate and who's not. Because one of the lessons we learned is that's where they're going to go anyway. And that doesn't mean you ignore serious concerns, but your picture of what that should look like for them and what their picture of what that looks like for them, you got to pay attention to that and say, okay, how can we make this happen for you where we think you're going to be safe and flourish? So I think our work is just beginning and thinking about that, and it's almost like rote. They reach a certain age, independent living. So I think there's still a lot of work to do around that. Or we'll say, well, we asked Beverly if she wanted to be adopted, and she said no. And we say, so she doesn't want to be adopted. Well, I may not even know what you're talking about. I mean, and what does that mean? And how do you even explore what those possibilities are and all that? So I think that's the work that continues and we're building on. But you direct staff out there, feel free to chime in and say, Miss Bev, you're wrong.
No. So I'm going to use your question as part of a ramp up, and thank you for acknowledging our transparency. LCFS, if you didn't know it, L stands for Lutheran. We come from a faith tradition and a place of faith that tells us and calls us not to just serve the individual children that we are blessed to serve, but to try to affect change in the greater systems and for all children. As you saw, Beverly put our whole population goal is that every child in the state of Illinois will have a loving forever family. So which is what led us to today's topic and to this gathering. And thank you again to both of our presenters. If you join me. So I wanted to purposely go back to this slide and again ask you to join us in your role, whatever it is as a stakeholder here, in addressing racism and addressing how children of color are treated differently in our society.